And now it's my great pleasure to introduce the next speaker, Professor Torsten Passie of the Hannover Medical School and the Goethe University in Frankfurt, formerly also a visiting scientist at Harvard Medical School. Please take the floor.
Thank you. Yeah, let's just introduce myself. I took a long walk to be here. It means in respect to time. So I started my research 35 years ago. And I have conducted some clinical studies with hallucinogenic drugs, as well as a lot of research about therapeutic use of psychedelic substances. I've worked with Hans-Karl Leuner, with the Swiss Physician Society for Psycholytic Therapy, with other people even in the underground, and so I've really searched through the field. And what I will give you or present here is an overview about the psychological as well as the neurophysiological mechanisms, as far as we know today, of MDMA-assisted psychotherapy, which is a fascinating topic to my eyes, because today we have, and yesterday we have seen results from studies and outcome measures and how they get better, the people and stuff like that, but we haven't looked into the psychological processes which are going on with these kind of therapies. So to give you a short overview, there will be an introduction, a short intro about group therapeutic work with psychedelics. Then I'm coming up with an interview study, what we have conducted in a scientific format. And out of that, we could define some psychological mechanisms. And I will also give you an overview about the neurobiological mechanisms as far as we know today. And there will be also a section about MDMA and trust, which I think gives an idea about the major feature of that kind of therapy. Okay, so the entactogens, you might know about them. They are different from the hallucinogenic drugs as LSD and psilocybin, which we have talked a lot about. There's no hallucinatory activity or pseudo-hallucinatory activity. There are much less cognitive alterations than with the hallucinogens. The ego functioning is usually intact. And there are specific anti-anxiety effects, as well as a kind of opening up in respect to communicating or the therapeutic alliance. And there are also reports about a lot of self-acceptance, feelings like that, and empathy. So the effects of MDMA specifically are mainly a psychophysical relaxation, very gravely, intensified feelings, euphoria, decreased anxiety. That was at first, when we started 30 years ago, it was our view that the main thing is that it reduces anxiety. There is an increased openness and communication, and there is enhanced closed-eyed imagery. That was what was known before we started. There's also frequently forgotten but important and intensified body experience with MDMA. So just to give you an idea that MDMA was used very early on, since 1977 in psychotherapy. Not very much is known. I have given an overview in this paper, which is available online free. What came out of all the early therapeutic use is a recommendation done by the World Health Organization when they had to prohibit the drug, right? And please read for yourself what they stated in their conclusions about the prohibition. And this was done in 1985, right? So 20 years later, we came up with the first study in respect to that. So, but what happened in between is that MDMA made another career as a dance drug, as you might know from these kind of settings, which are quite different. I call it the extroverted use of MDMA in comparison to the introverted use, which you might see here, if it works. Okay. So this is a typical psycholytic setting, as we call it in German, or it was also used in Sweden, by the way, in the 1960s. There's one person accompanying the patient, lying here, and this is Professor Leuner here in the center. So that's a typical kind of setting what you have in these therapeutic applications. But, however, there were also uses of LSD, MDA, and other MDMA in group therapeutic settings, which I found personally very interesting. At first, I was anxious about it, but later on, when I studied that, it also has a certain history. So Hoffa and Blewett in Canada at first were giving, to be more effective, they gave it to 3 to 4 patients in a group setting. Fontana in Argentina has done that in larger groups with the same substances. Spencer has done that with LSD in the UK. And Hausner and Dolezal in Czechoslovakia for quite a while, as you can see. And Derbolowski in Germany has also done in a kind of private clinic these kind of group work. So it's not unknown from history. And quite a bit later, the ZEPT Society, the Swiss Physician Society for Psycholytic Therapy, exists since 1985. And they have conducted this group work during these years when they had permission to conduct these therapeutic work. The group method is in a way quite simple. These are designed as weekend workshops with 8 to 15 participants. You have 3 therapists on the spot, 2 males, usually 1 female. Patients are prepared by psychotherapy, usually more long-term as we have it in Europe, like 30 hours, 50 hours, somewhat like that. And it is a structured but somewhat permissive setting which is provided to the patients. And you also have to take care about the furniture and the rooms. They should be agreeable and stuff like that. So this is here my psychedelic lab at Hanover Medical School. What is also needed is a mattress, a blanket, cushions, headphones, usually eye shades, and the instruction to focus inside. The people are allowed later on in the session to interact with each other, do communication and hug and stuff like that, but in the first few hours they should try to stay inside. What kind of diagnosis did we do there? Okay, character neurosis. That's another term for personality disorders. I don't like the term disorders. I recently found a book there where they mentioned 35 times on one page the term disorder. So, I mean, we're talking about humans, right? What's going on here? Okay, so we had anxiety patients, we had depressive patients, life crisis or spiritual crisis, which is not meant in the sense of being psychotic and being in a spiritual crisis. It's more a general kind of thing, what even a healthy person can. Psychosomatic diseases, anxiety with life-threatening disease we have also treated, and some PTSD cases in these settings. So we conducted an interview studies with 8 former patients. These were semi-structured, in-depth interviews following a scientific design, and they were 5 of these transcripts, which were transcribed word by word, were used in a diploma thesis, which was accepted at a major German university. And we did a content analysis to the contents of the interviews, as established by Meyring, a major figure in the psychological field in respect to content analysis or qualitative research. And we also did a phenomenological analysis following principles of Mustakas and Edmund Husserl and so on, and we published a book about it a while later. These are the 2 books. That's the German one. This is the one which, a kind of translation, but a little bit extended, appeared with maps in the US. So our focus with that interview study, what we want to find out about the mechanism of these changes which the people experienced on a psychological level mainly. And so what we found is these are the extracts from these interviews. So that was a major topic, the psychophysical relaxation, what the people experience. We know that, the opening up and the decrease of anxiety, an altered experience of the body. These were reported in the interviews by the patients, and we have extracted these features. And also trust building was a major feature, was what was mentioned quite a lot of times. And also age regression, so that the person who feels like a child really feels like a child, even owning the body of a child and stuff like that. So it's very authentic, so to say. There were some psychological processes going on, like the activation of emotions. You feel more usually, even if it's primarily in the euphoric directions with MDMA. And you have enhanced imagery, and there I just want to remark that if you have people sitting in a laboratory and they are under the influence of LSD, they report pseudo-hallucinations. If they sit there under the influence of MDMA, they report nothing with open eyes. But if you have them in a therapeutic setting and you do the questionnaires, they have the same amount of visual imagery with closed eyes than with LSD. So just to remark that. So there was a certain speeding up of intra-psychological processes, so kind of the psychological activity was kind of speeded up. There was an obvious reprocessing of traumatic events, not in all patients and not all the time, but a lot of times. There was also catharsis. As you might know, people began to weep, they laugh, they get angry, stuff like that, so evocation of emotions, if you want. And usually it was said that they felt cleaner afterwards. There were also something, what they call problem actualization in psychotherapy research, which is you're not going somewhere else to God or outside of your usual reality, you go into your problems. And that, it seems with MDMA in a therapeutic setting, that's a more kind of automatic thing, that the people are going where their problems are. So this is called problem actualization. There was also an immediate transparency of transference phenomena, as you might know, that if there is an older therapist, you might project your father image on him, and then you tackle with that difficulties which might result from that. But these things become immediately transparent to the patients usually, even if they act like that. There were also mental alternative simulation. What is meant by that? That is, for example, I remember a patient who was, she lived alone with her mother, and the mother was very invasive. She came into the room immediately, all the time, you know, didn't knock and stuff like that. And she re-experienced that scenery in the, during the MDMA trip, and she was telling her, "Go out of here!" You know, so it means there was something different going on, so go out of my space, right? So she simulated something which she hadn't done before. There's also a kind of de-schematization. So if you have your usual thoughts, for example, we had another patient in treatment who had experienced a divorce of the parents, and she was always mad at her parents that they did that and for tens of years. And under the influence of the drug, she realized that was a bad thing they could do, you know, at that point of time and in respect to them. But she didn't realize that before, even she was 42 years old or something. But under the drug, and that knowledge never has gone then, you know. There are also usually kind of new perspectives, so you put things into perspective. You don't look at them as, oh, this was this way. You know, it might have been a different meaning and significance if you put it into a longer line of events and contextualize it differently. And this is a very important point. You know that from psychotherapy as the usual thing, that there are corrective new experiences, means that you make experiences with others, for example, which are kind of counterintuitive to your belief system. And especially in the interpersonal sphere, if these groups are working together, you know, they make a lot of different experiences, and so they can trust the others much more. So it's furthering interpersonal trust, if you want. So now I will give you some ideas about the neurobiological mechanisms which can be figured out from the scientific literature. I mean, these data which I have used to put that model together are recruited from scientific studies. So this is a brain, as you might know, and here is the amygdala, this is the hippocampus, and this is the limbic system, here's the frontal cortex, and what I want to tell you at first is an explanation about what is a trauma. So according to Freud, a trauma is something which an experience you can't cope with your usual psychological mechanisms. So your system is kind of overwhelmed, right? And so you store it, I guess, differently. And that was exactly what the research is showing. So if a usual experience is coming to your mind, like this lecture, for example, you get it from your occipital cortex, the optical impressions, right, from here. Then they go to the thalamus, then you check them with your cortex, what is important, what not, and how can I sort that in an appropriate fashion. And then you're sending back a signal to the thalamus, okay, store it, this and this and this part in your memory bank. And then you store it in the hippocampus, right? So with a traumatic event, it's a different deal. So usually you have an experience and it directly goes to the memory storage. So you don't have the ability to cope with it and to sort it out in a certain fashion and to validate it appropriately. And this is the reason that people experience flashbacks. So these are unsorted, unintegrated experiences, and usually if the flashback is a heavy flashback, you have the real experience coming back. So it shows to you that it is not sorted out and not appropriately stored. And also in nightmares, these things show up again, right? We know that from the patients. And so it's an unsorted memory in this model. And what we know is that in PTSD, you have a disbalance in between the amygdala, which is this brain center, fear center, and between the prefrontal cortex, which is usually kind of controlling the amygdala, right? But if you are really threatened by a traumatic event, the amygdala goes higher, even on a chronic basis, and the prefrontal cortex is going down in its activity. Yeah, so it's a dysfunctional thing. With MDMA, there is an increased activity in the medial, ventromedial prefrontal cortex and decreased activity in the amygdala. So you're kind of putting the balance in another direction under the influence of the drug, right? This reduces emotional avoidance, so you're not avoiding your memory anymore as you usually do with a traumatic event, and it permits to revisit the trauma, so to say. So if we go back to the picture again, not perfect, but however, so the idea is that there is a certain kind of tension system engraved in your hippocampus, so to say, which kind of tries to express itself in nightmares, in flashbacks, and so on. So it's a kind of tension system built up there. Usually, your amygdala will hinder the upcoming or the reappearance of these memories, right? Because you're more anxious, so that you're suppressing these memories. So what has been shown with MDMA or MDE, which is kind of the same substance by, for example, Gutzoulis-Malfrank, but also by Gamma and other researchers, but it was kind of the first study ever. And this is a PET scan. You have seen it, I guess. It means that the more orange or red the color is here, the more activity you have, and this blue stuff is where the activity is kind of low. And what you can see here is the area where the amygdala, these are templates from the brain, there you see, and you can see that here, so the amygdala is definitely deactivated, and that's a consistent finding from these imaging studies. So the model might work. So what happens then? I just want to show you this here. So this is another kind of template, and here you see that the prefrontal cortex is activated during the action of MDMA, right? Or MDE. And what does it mean to our model here? This is the attention system is there, but if you eliminate kind of or limit the activity of the amygdala by a strengthened prefrontal activity and also by a deactivation of the amygdala, you know, then these tension system might still be eager to express themselves, and they bring the memories to the thalamus again, and then to the cortex, and then you are able, because the amygdala is not suppressing the memory anymore, to sort them out and store them appropriately in the hippocampus. That's one model how you can explain some trauma healing effects of MDMA. Okay, then we come to another kind of neurobiological mechanism which we found out about during the work what we have done, which is we had some observations. For example, people got kind of feelings of trust and closeness with others in the groups. And they enjoy intimate communication with each other. But we never came across a couple building out of the therapeutic group sessions. And we never came across people which have called up each other after the session. Oh, I give you my phone number, you're very sympathetic, you know, we talked so nice and stuff like that. It wasn't that way. They talked very intimately, but they didn't come up with each other again afterwards. That's what I was wondering about. How did that happen? And the group settings, if you let them more free, they tend to end up in piles, you know, like people come together and they're really close with each other, etc. But there was just non-genital body contact. The genital area in general is not activated. I will go into that in a moment. But there's no sexual urge or activity during these sessions. We never came across sexual action in these groups. And there are obviously therapeutic effects of this closeness, especially with people which are very shy about others and can't communicate so easily and have a lot of social inhibitions. So I use this picture to illustrate what's happened in these groups because I don't want to give you the real thing, especially not here. This is what I call non-sexual body contact. It's a painting by Gustav Klimt, a prominent artist, and he has done a few of these things, and this is exactly how it looks like, usually, if you let the groups perform freely, more or less. Okay, now we are coming to a funny thing, which is I theorize that the MDMA-induced state in its typical form is equivalent to the post-orgasmic state. And therefore, I show you a picture about the arousal and intensity of the experience during a usual sexual intercourse. And you see the orgasm is the peak of the matter. Usually, they have a kind of arousal phase and the plateau. And then, and this is important for our thing here, this is arousal phase. And there is also the post-orgasmic state. Interestingly enough, everybody is interested in sex, but nobody is interested in post-orgasmic states. If you look at PubMed, you will find 2 publications. So interestingly enough, right? However, everybody want to be there, but they are more interested in how to go there than be there. However, okay, so what we have found in studies conducted at Hanover Medical School, because we got enough of all these studies putting people masturbating in the scanner, you know. So we were looking out for having couples, real couples, you know, and we made kind of announcements, and the study was kept completely secret. So we had drilled a little hole in the wall so that we could put them on the online and blood picking stuff and so on, and then they were left for free. Out of 24 subjects, 23 had an orgasm in this, so it was an appropriate setting, I would say. However, what we have found and discovered, in fact, it was a huge discovery in sexual science, not by me, but by these guys here, Krüger and my colleagues. What they found is that if you have, here you have the arousal phase again, and this is what happens to your prolactin level if you are not having an orgasm, right? If you're sexually aroused but not having an orgasm. So it even goes down somewhat, right? But what happens if you have an orgasm at that place is it goes really up, the prolactin, right? Meanwhile, we think from a scientific point of view in respect to sexual science that this phase, the so-called saturation phase or refractory period where you can't get an erection anymore and you can't get an orgasm anymore after you had one, not with females or some of them, but with males, it's obvious. And so this is called the saturational period. And you see that the prolactin levels were getting higher, kind of tens of %. And what happens with MDMA is that you have the acute psychotropic effects for kind of 4 hours or a little more, and the prolactin is going that way. So this is why most people, virtually all, have no sexual urge when they are under the influence of MDMA, and they can't even conduct sexual performance. Usually because it seems that the prolactin is correlating with this saturation period. And so, yeah, okay, that's no sexual urge. inability for, I already said that, in the saturation period. So we have published about that finding because it was a clinical finding from our therapeutic work. And as you can see here, there are a lot of similarities about these two states. Oh yeah, that was the most interesting, because I was giving a lecture at the Tucson Consciousness Conference, and I was on stage with Barry Komisaruk, and he is the only one at that point of time who really did imaging studies with sexually aroused people. And so I was asking him on the stage, what do you know about the post-orgasmic state? You know, did you really finish the machinery at that point when they had the orgasm, or did you let it go? Yeah, and he said, yeah, we let it go. And I said, you didn't publish anything. No, we didn't publish anything. What's the main thing? And he said, the deactivation of the left amygdala. That was their finding from the post-orgasmic state imaging study. However, so you also have these neuroendocrine similarities. The emotions are usually intensified. The anxiety is much reduced. Thinking is more imaginative. Body experience intensified. And the mindset is opened up. And if you look out for, if MDMA, what is my hypothesis from the clinical work, is mainly a booster of trust. How do you define a state in which you trust to the maximum? It might be the post-orgasmic state. If you have access to that state, you might have a nice life. But also, I think it's an equivalent of a very trusting state. You know, completely relaxed, the anxiety is gone, you're quite open, everything is all right, you feel even oneness might be, and so on. So I think that, oh I don't know what happened here. So we also know that MDMA is inducing the secretion of oxytocin, and oxytocin is somewhat, don't believe in the button theories, they are too simple, is somewhat involved in trust and empathy, and it mediates anxiety in social situations. It is also involved in the therapeutic alliance, as far as we know, especially in PTSD, and that is essential for therapeutic work with PTSD patients. MDMA increases oxytocin, as you might know, and it strengthens usually the therapeutic alliance and also the feelings of trust. It also enhances the encoding of positive social memories, and I'll give you the literature too. And another thing what MDMA does is it also secretes some other hormones like cortisol and norepinephrine, which trigger emotional learning and also including fear extinction. Cortisol enhances extinction learning especially, and MDMA increases both of these hormones. You know? And so at last we have a pretty interesting medication, which in the former times, as it was explained, I think also by Dave Nichols and by others here, we don't have that kind of target-oriented thing anymore. So in the former times, our drugs were called dirty drugs because they just not hitting that one receptor subtype, you know, and nothing else, like ketanserine, for example, which is also a little dirty drug, but however, you know, and so right now we are looking out for substances which alter the brain matrix as a whole thing and to conduct healing processes, so to say. And so right now the mind of the medical profession is changing, of the pharmacologists. They say, meanwhile, you don't have a dirty drug, you have a pharmacologically rich drug. Okay, so remember that. So, however, we have three different factors going on with MDMA therapy. Activation of the ventromedial prefrontal cortex, deactivation of the amygdala, that allows reprocessing and integration of traumatic experiences. The other thing is prolactin and oxytocin, they further relaxation and trust and the encoding of positive relationship experiences. Then we have cortisol and noradrenaline triggering of learning and extinction. And all these processes go together, right? Yeah. And so this is really pharmacologically rich, and it can really help people. So what is the mechanism of action from my clinical perspective? This is not real science in that sense, in a more strict one. But what we found is there is trust building into your emotion. There is trust building into your body and its functioning, and that it's good to be in there. There's also a triggering of interpersonal trust, as we have seen in groups. It's quite a contributing factor to my eyes. And there are also transpersonal experiences with MDMA, which are not as much in respect to ego dissolution, or the psychiatrists call ego dissolution kind of depersonalization, because your kind of the personal image is gone. But it's more like personalization. So it's a different form of ecstatic state, if you want, that you go more into your contact with yourself because you're not determined by anxiety anymore, and it broadens your scope and your experience with yourself and also with the others. That's a transpersonal experience somewhat, but it's a personal transpersonal experience, if you want, because it transcends your usual self-perception. Also important is the integration of the experience, where we took a lot of care of. And as I have already mentioned, the persons are in a longer therapeutic process, usually lasting 100 hours plus minus 50. And so we these therapeutic processes interspersed with 3 to 10 sessions with MDMA or LSD-assisted psychotherapy. And there is also the activation of self-healing powers. After doing that work for 20 years, I came to the conclusion what we are doing here is moderating self-healing processes. We are not the omnipotent doctors, which I'll give you the pill, I'm the healer, no. We just moderate that. We facilitate something, but we are not really causing it in that sense. So I just want to give you the results from Michael Mithoefer's study, just to impress you a little. So this is the CAP score, the clinician-administered PTSD scale. And these are very high symptom scores of the group. The first study was done in the US by Michael Mithoefer et al. And here you see the MDMA-assisted sessions, so they really go down in respect to their scores. And it's also noteworthy that these results are stable over a period of 3 years. And I also want to remind you that right now we exclude a lot of patients from the phase 3 studies for some reasons, which are reasonable. But in this first studies, a lot of different people were treated coming from sexual trauma, like being raped for years in a family system, and as well as being a veteran or a fireman or something like that, being traumatized sometimes just one time, like a raped woman, but all had the same success. You can't tell me that they all reprocessed their trauma from years, in comparison to one rape, But the trust building, that factor, that might be universal in that kind of therapeutic work. However, are there safety issues, as far as we can tell from the Swiss physicians which have conducted work on and others? No major physical complications were ever seen, and they had a broad spectrum, including diabetes and high blood pressure and so on. No psychosis ever happened, no suicide. Panic reactions are very rare. They can appear in the beginning of the session for usually a few minutes, or maybe even 10 or 15 minutes, but not longer usually. What's about unresolved issues which you couldn't complete in one session, so that you might struggle with them afterwards and stuff like that? This is where you have to hook in with continuing psychotherapy during the aftermath. And what's about mood swings? Especially that can happen with people which have a kind of narcissistic construction about themselves and about their habits and how good they are and stuff like that. And they might get much more humble when they see themselves in this different kind of inner context. And so they might not be able to cope with that as easily. So they might go into mood swings and labelization kind of things. Then you have to take care of them afterwards. But that can be done in a usual outpatient office setting. And there are also problems with therapists, especially in the underground, where you don't have that much control. You know, they go into megalomania, they take other drugs, they treat their patients the wrong way, they dissolve boundaries in a lot of respects, sometimes even having sexual relationships, as it was known from the early years too, that some people got tempted to do these kind of things because we hadn't known so much about the substance. And here are my conclusions. So there are distinct neurobiological effects from MDMA, which can be used in psychotherapy. The amygdala deactivation might be the main factor of that. There are diverse psychological mechanisms going on during that kind of therapeutic work. And trust building might be a major factor. However, we can explain that. We might have a hint of an idea about the post-orgasmic state and these kind of states, that they might be also a different specialized form of ecstatic states going beyond your usual ego range in experiencing yourself. However, the group setting, I really argue for the group setting because it really adds to the effects of these drugs in respect to therapeutic work. And at last, don't forget the hindrances. In the medical professions, we have certain hindrances, which I call the taboos of Western medicine, which is alteration of self-control. No physician would be okay with alteration of self-control. There are very few ones here, but I mean, usually they are not. And if you have a person doing surgery on you, you don't want to have him losing self-control, right? Or the person on the machinery with the narcotics and the oxygen stuff, you know, you don't want to hate him, oh, I lose self-control, I'm tripping, you know. No, you don't want that. So it's understandable, but physicians are usually very strict in that respect. They have a kind of mental attitude in that direction. So you will not have an easy time to confirm them that losing self-control is something positive. So that's against their usual paradigm, right? Intense feelings. You know, even in the clinic where I do my conventional psychotherapeutic work, I know that a lot of my colleagues have a lot of anxiety about the feelings of the patients. And the patients told me sometimes, I've immediately detected that you're not anxious about emotions. And so they let go in the session, but with the others, I immediately detected they are anxious about my emotions. And one background of that might be that you kind of getting infected by the suffering of the patients somewhat. You know, it impregnates you, it even goes into you somewhat, burnout and these kind of things. You know, so you should take care that you're not getting too much of it. But on the other side, you should be open so that the patients can have more emotions. But that's also a thing which we really have to look out for if our colleagues can handle that, and even you, I don't know about that. And the next problem, and that's a serious one, is touch. Because of that post-orgasmic state thing, we can really touch the patient without any sexual urge, even in the therapists, because they are beyond that. You know, there's no libido to project around or something like that. And so it is an important feature that we, not just the therapists, even the patients with each other can come very close and hug each other and stuff like that. That can be a productive factor in the therapeutic work, but it looks very suspicious to a lot of physicians and psychotherapists. And so therefore, for example, Hans Karl Leuner told me, yeah, with psycholytic work in the beginning of the 1990s, we had no idea about MDMA-assisted psychotherapy. He told me, you have to touch the patient somewhat, but just do it above the shoulders. So you can touch the arm, you can touch the head, and do everything, he said to me, what you would do to a child. You know, you can caress and stuff, you can just put the hand here or so, but don't go below the shoulders. I think that's a good regulation somewhat, you know, if we have to have body contact. And you also know that beyond the established psychotherapeutic methods, there are a lot of methods out there which use the body. And so it's not quite unusual, but it's unusual for medical doctors, which will at last apply these substances. Okay, that was my presentation. Thanks. Oh, just a word, I forgot that always, about advertisement. So I brought some of these books. If somebody want to buy one, it's 15 euros. So just to let you know. Okay, thank you.
Thank you very much, Torsten, for this very thoughtful and thought-provoking talk. We do have time for questions, so please come up and grab the microphone and ask your question.
No question left.
We have one question coming up. Please come forward and take the microphone so everyone can hear you, and also for the benefit of the recording.
Yeah, thank you.
Thank you for your talk. I was very interested on your slide about prolactin and the pre- and post-orgasmic state. Have you looked at what happens to oxytocin? Because I've been doing some research into this, you know, that it's produced when women deliver their babies, and they're calling it the love chemical, that this chemical released is what creates empathy for the baby, and everybody in the room is feeling. So we started to use it nasally on some patients, trying to assess, you know, was this really a love chemical? And some people related they felt similar effects to MDMA from the use of nasal oxytocin. So I was curious if you have any information about this.
Yeah, so after orgasm it also gets a little higher, but it's kind of not really significant. And we did a lot of research in respect to the effects on normals. I wasn't involved in the research, but I was involved in the testing. And so I did some nasal in different dosages, and it does something, but you have a really hard time to measure that. And even subjectively, you don't feel as much altered. And so I'm a little skeptic about this love chemical kind of thing, you know,
yeah,
like pushing a button somewhere in such a complex machinery. I don't know about all these.
Yeah, I agree. It was very subtle, and it was hard to tell, was this placebo effect or really, you know?
Yeah. No, there are some effects which have been measured, but they are kind of tiny. You're not a loving person because of having some oxytocin. Yeah.
Thank you.
More stuff involved.
Thank you very much, Torsten.
Yeah.